University in thoracic surgery. He'll be talking about chatbot use in thoracic surgery and clinical scenarios. Thank you for joining us.
Thank you guys very much. Again, my name is Joe Platz. I'm a thoracic surgeon out of St. Louis, and I'll be talking about AI use, but specifically chatbot use in clinical decision making. So it's an excellent kind of introduction. I don't have to go through much of my background at all. I have no disclosures. I guess I was asked to say that most of this data is currently under publication, so don't reproduce. A lot of you know that some degree of AI, or at least machine learning, has been in medicine for quite some time. We've been analyzing histologic slides, radiologic images, but previously this technology required a certain degree of expertise. But with the integration of machine learning, large language models, the creation of what we call generative AI, and these chatbots, internet-based, it's really open to the public being us as physicians as well. And already, use in medicine has been promising. It's shown to be very effective at answering simple medical questions, helping manage medications, giving differential diagnoses, even passing medical standardized testing, whether that's good or bad. So in the global sense, this has a lot of promise. This could essentially serve as an expert consult for those who live in areas where they don't necessarily have the infrastructure, the specialists, the hospitals to reach out otherwise. However, there's also been significant concerns, especially as the clinical questions get more complex, as to accuracy, reliability, reproducibility, and then hallucination, which is this interesting concept within these LLMs where there's this cyclical, self-imposed presentation of incorrect data that can occur. So, my group out of St. Louis University and University of Chicago wished to see in a real world, realistic scenario, if you were in clinic or the hospital and you had a difficult patient presentation, can you reliably log onto the internet and use one of these chatbots to help you through? We wanted to determine accuracy and reliability. We also wanted to see if there's any improvement over time. And then again, we really did try to keep this as real world as possible. So there are a number of protocols out there to help pre-train or educate or template these chatbots to improve results. But realistically, that's not something you're going to do on a day-to-day basis. So we tried to keep things simple. We started out by creating clinical scenarios using our American Board of Thoracic Surgery domains. So essentially, these are the domains we use to train our residents and then eventually test them on the boards. We created these using the key features method, which is something many of you may have used, but essentially it's just a validated tool to create high quality questions, and something we are integrating into our board exams. Of all the scenarios we made, we eventually picked 12, which we thought were the highest quality. Within each scenario, there were 3 question stems, each of which were worth a possible 1 point. And then before running any of this through the chatbots, we came together and determined what would be considered a critical fail. So just like the oral boards, we determined what answers were not just wrong, but were unsafe or egregious. Again, I mentioned that we tried to keep this as accurate to a real world scenario as possible, so we used our normal clinical language, normal abbreviations. Then all 12 scenarios were run through, at the time, the 4 most common and up-to-date chatbots on the market. That was ChatGPT-4, Cloud 2, Bard, which is now Gemini, and Perplexity. And we didn't just run it through each chatbot through once, but we did it at 3 separate time intervals, several weeks apart, to see if there was any change. Scoring was performed by each individual surgeon, but then we came together in consensus. So if you remember, there's 3 possible points per scenario. We determined a passing score to be 2 out of 3. This was admittedly arbitrary, but 2 out of 3 or 66% aligns somewhat well with kind of a classic A through F scoring method. Also, if the chatbots received a critical fail, their score would be 0. This is just a look. I know the text is small, but at one of our scenarios, Classically, most of our STEM ones or our first questions were a classic written board style HPI or patient presentation with a question attached. Here you can see a patient's presenting with a new lung lesion and we ask for a differential diagnosis. The chatbot would then give us an answer and we would present additional information and another question. In this one, we ask for appropriate workup. STEM 3 here are some true and false questions relating to the top. So all the scenarios were slightly different, but followed this same approach. So how did the chatbots do? The short answer is not terribly well. This is a breakdown of all 4 chatbots. You can see the 3 testing runs per, and then the mean raw scores as well as the critical fails. If you look at that dark gray row, that's the raw scores. You can see most of those are below that 2-point threshold, and some of them significantly so. But perhaps even more concerning than that are the critical fails. If you remember, we had 12 scenarios, which means 36 stems or 36 questions. And if you look closely at some of those numbers, it's a really high percentage that they critically failed. So again, these are not just wrong, they're unsafe. This is another way of looking at that mean data, that raw score data. Again, broken down by chatbot. The x-axis here are the 12 scenarios. Each line represents a separate testing run. So if we look at ChatGPT, for example, there's some good questions, there's some bad questions, but what you can see is that it's fairly consistent, meaning those lines are right on top of each other. If you look at Cloud 2, the results, the scores aren't quite as high, but it did have the most improvement of all the chatbots. That you can tell because that yellowish green line, the last run, for every single question is improved upon its previous runs. And then BARD and Perplexity are a little bit more all over the place with more crossing lines. Here's a look at the critical fail results as opposed to the raw scores. The trends are fairly similar. So ChatGPT performed the best with the least critical fails and the most consistency, kind of a flat line across those bars. Cloud 2 demonstrated the most improvement. So you can see those bars steadily decrease in number of critical fails over each run, eventually mirroring ChatGPT scores. And then BARD and Perplexity, again, were a bit less consistent and with worse scores. Interestingly, also, if you look at here, you'll see that all the chatbots other than Cloud 2 demonstrated improvement between runs 2 and 3, but actually worsened between runs 2 and 3. So overall, as I said, ChatGPT stood out as being the most accurate, having the least critical fails, but did not improve significantly over time, and we'll talk about that a little bit later. But Cloud 2 is the only one to show a statistically significant improvement over time. And then BARD and Perplexity were the most inconsistent with the worst scores. BARD in particular was interesting in that it frankly refused to answer a number of questions, which certainly negatively affected its scores, but perhaps in the big picture, that's a good thing. Perhaps you want your chatbot to refuse to answer questions that it doesn't know the answer to, instead of confidently giving an answer that is erroneous. But overall, the scores were low, and perhaps, as I said, more concerning were the number of critical fails. Again, these were unsafe answers that someone would fail an oral board for. So shortcomings, there were certainly some in this study. I think going back to what I said earlier, we really tried to make this as real-world applicable as possible, but in doing so, we did not use certain protocols to pre-train or train after each session the chatbots. Also, in terms of our scoring, as I said, our pass-fail threshold of 2 points is totally arbitrary. We tried to make it line up with more traditional scoring methods, but admittedly it was arbitrary. And then lastly, in terms of scoring, the mean, there's a statistical difference between the mean scores per scenario, suggesting that some of our scenarios were either difficult or poorly written. I guess we can't say why, but there was certainly a statistical significance. But based on these results, where do we go in the future? I think there's really 3 main categories that we need to look at in the future when using these chatbots. One is just that they will continue to get better. As we saw in our last talk, there's been huge progress just in the past 2 years since 2022 when essentially these came out. Now, we didn't see this in our study, and perhaps that's just because we didn't look at a long enough timeline, but things will improve. And so I think it's on us as surgeons and as a society to continue to evaluate this. And maybe it's not ready right now, but it will be. And it's on us to determine when that is the case. The other thing is we need to compare these chatbot results to surgeon results. Certainly here we did not see excellent results from the chatbots, but say if we did this test with the surgeons and we had similar results, well, perhaps that's a problem with our methods and not the chatbots. That being said, I'll tell you that we're well underway in that comparison. In fact, my colleague is going to be presenting that data at our National Thoracic Conference, I think, tomorrow. And the surgeons did much better than the chatbots, particularly interestingly with critical fails. And so the surgeons still had multiple answers where their scores were low, but they had very few unsafe answers, unlike the chatbots. And then the huge one, which I know they've talked about in some other sessions, is data sharing. And this generative AI, these large language models are only as good as the data they're trained on. And so I think we as surgeons, but probably more as surgical societies, are going to be forced in the next months to years to discuss whether we want to actively participate in data sharing. Do we want to share our databases, our textbooks, our financial records in order to improve the quality of these AI or these chatbots, or do we want to sit back and see how things go? And it's a hard decision. There's a lot of privacy aspects, financial, competition concerns related to it. But in summary, AI and chatbot use in medicine is growing exponentially. Essentially anything that we used to Google, people are now putting into a chatbot. It's made even more complicated because now Google is using Gemini within their internet searches. The big difference that studies are finding is that when we used to Google something or look something up on the internet, we would use some degree of critical analysis to determine what search results seemed valid. There's a lot of evidence that people don't do that anymore with chatbots. If you put something into a chatbot, you believe what it tells you. It is considered truth. We found here that that's not always the case, so that can be dangerous. So all the more reason that we need to ensure accuracy, reliability, reproducibility, and absence of hallucination. But again, it will improve over time. I think it's going to really hinge upon us to help that process, or at least determine what role we want to take as surgeons in improving the accuracy with data sharing. But for now, like anything else, these chatbots are a tool. They certainly have benefit, but you have to look at them critically and cautiously with the answers you receive. Thank you so much.
Thank you, that's great. Our next speaker is Yalini Vigneswaran, my co-moderator from Chicago. Innovative posterior rectus sheath flap, superior paraesophageal hernia repair. So, take it away.
Well, thank you for allowing me to present my work here. So I'm going to talk about surgical innovation that we've been working on and share my experience with how to not only innovate, but how to disseminate that knowledge in an ethical way in this context of innovation and AI. So even if you don't do paraesophageal hernias, I hope you can learn from my experience with this. So, you know, as we've learned, there's a lot of new technology and it's rapidly growing in terms of how it's going to apply to our practices. One of those examples is robotic surgery, and the new technology alone is not what makes innovation, but it's how we bring it to our clinical practices and how we will innovate using the new technologies. And so this is kind of an example of how we've done that and following certain frameworks and how we should do it safely and ethically. And so I'm an MI surgeon. I do a lot of esophageal foregut surgery. One of the most challenging problems we face is large, complex, and recurrent paraesophageal hernias. There's high long-term recurrence rates. We've tried many different applications to reduce these risks, including mesh. Mesh does not reduce the recurrences and often has a lot of risks associated with them. So, we attempt to solve this problem. So first, by solving the problem, we want to understand why a paraesophageal hernia repair fails. And our hypothesis is that it really violates the major tenets of any kind of hernia repair. Hernias, when we talk about abdominal wall hernias, we don't reapproximate the muscle, we are approximating the fascia, because we know the muscle itself does not have the tensile strength required to have a durable response. But with the hiatus, we are very limited because we really have this denuded crural muscle that we're left with that we are often reapproximating. It's not often a tension-free repair. As you can see here, this is an example of a primary repair I've done. It can be in some cases, not so much in this video, but severely attenuated and weak crural tissue. And we're repairing a highly dynamic diaphragm muscle. And so we're doing a subpar repair in a very dynamic area. And so a lot of these probably lead to some of the reasons for failure. So I was doing one of these repairs once, and Larry Gottlieb, who's one of our plastic surgeons, walked in the room, and he said, "What are you doing? Why do you think that's going to work? There's no way that's going to work. You're just sewing muscle to muscle. Does this actually work?" And we tell him, no, it doesn't actually work. We have high recurrence rates. And so he had actually come up with this technique for abdominal wall for transplantation. So in pediatric patients who receive livers, oftentimes closing the abdomen can be difficult because you've lost a lot of domain. And so he developed this technique where when they harvested the liver, they actually harvested not just the liver, but also the posterior rectus muscle, and the rectus, like the abdominal wall, attached through the falciform with the liver, transplanted the liver and the abdominal wall to help close the abdomen. And so here's some examples from his published work in terms of how they were able to do that. Obviously, I'm not a transplant surgeon, and that's not what we're doing, but we were trying to see if we can use a similar concept with that type of anatomical considerations and plastic reconstructive techniques to use the posterior rectus sheath to reconstruct the diaphragm. And so John Alberti is one of my senior partners, and I think an important part of surgical innovation is making sure that your team and your program and your section supports you, because obviously you don't know what the long-term outcomes of doing these types of things are. And so John really helped me develop this. And so we decided if we could use the rectus fascia, we would provide fascial strength. It would be peritonealized, so we don't have, hopefully, that same kind of reaction we get to mesh at the diaphragm. It's a dynamic tissue, as we're dynamic at the diaphragm, and it's vascularized if we can maintain the vascular pedicle to this flap. And so I also do a lot of abdominal wall surgery, and so using a lot of the same principles of what we do with ETAPs and a way we do abdominal wall now, we developed this idea where we just resected the posterior rectus sheath, maintaining the integrity of the abdominal wall by maintaining linea alba and semilunaris. And so on the, this is a picture of when we do these ETAPs to give you an idea of the plane we're in. We're in this pre-peritoneal plane at linea alba, so that linea alba actually is maintained and stays up. But the falciform ligament is where the vascular supply is to this. And then we incise the medial edge of the right posterior rectus sheath to get into this plane posterior to the rectus muscle. And so here's a little diagram showing kind of what we're resecting here is the posterior rectus sheath based off of the falciform and the round ligament that goes through, the vessel connects through to the liver through the middle hepatic. And so this is just a little diagram showing of me harvesting this flap, the top left. We got the flap attached to the vascular pedal on the bottom, and then we are bringing that over under the liver to the diaphragm. And so we secure the diaphragm, and really the technique has evolved over time, and I'll talk about that a little bit. I don't know if these videos will play. But this is a quick video. I won't play all the videos here, but this is us using the robotic platform, because with the robot we're able to put the ports fairly low, and I can use the same port sites to harvest this flap and do the hiatal dissection and repair. And so here I'm maintaining that linea semilunaris out laterally incising the lateral border of the posterior rectus sheath flap. And then medially, we incise, this is where the vascular pedicle is, so right up midline, linea alba, I'm incising the peritoneum to take the preperitoneal fat and vessel while maintaining linea alba up. And this vessel, we can use ICG here, sometimes I use this to better identify where that vascular pedicle is. It goes all the way down the falciform into the liver to the middle hepatic. And so we're able to mobilize that whole vascular pedicle and keep that in continuity with the fascia. Here I'm dividing the medial edge of the posterior rectus sheath. These planes can be a little bit difficult to fully understand until you've done a number of them, but we continue this plane and take the posterior rectus sheath fully off the posterior rectus muscle. You know, when we do abdominal wall reconstruction, we really do believe that a lot of the strength comes from the anterior fascia, and that the posterior fascia may or may not play a large role in the abdominal wall strength. And so based off of that and maintaining linea alba and semilunaris, we hope and believe that abdominal wall integrity can be maintained. And so that's the end of that. We've got that fascia off. Immobilize the pedicle, and it just falls right nicely under that lateral fissure of the liver, and can be rotated up towards the diaphragm. You can see that goes up without tension. We have a nice piece of fascia to bring up to our diaphragmatic defect. It's strong, it's peritonealized, it's vascularized, and I'll just show the last video is just how we've developed this technique. So now I use this like an incorporated mesh technique where I'll actually incorporate the fascia into the cheiroplasty. And depending on the size of how much I can harvest, you can actually put it all the way around the esophagus. And I do put it really snugly around the esophagus. Haven't had any problems with dysphagia. Obviously it's a native biologic tissue, so it shouldn't have the same reaction as a mesh, and it stretches very nicely around. I won't play this video, but sometimes I will put relaxing incisions around the diaphragm and actually cover this whole fascia over that. You can see here, you can put the fascia all the way around the esophagus. I do secure it to the left side of the diaphragm. You know, if you do a lot of revisional surgery, you know a lot of recurrences often happen on the left anterior portion, and so this can cover that whole area up really nicely. You know, in the context of this panel, we're talking about surgical innovation, and when you do something different in the operating room, it's kind of you know, difficult to decide when is it enough variation that it's a new procedure and it's a true surgical innovation, versus it's just like I'm changing the suture I'm using, or I'm putting a different type of throw in here. And so I think, you know, deciding where that line is, and this is something that we decided is a different procedure. We don't know what the long-term outcomes will be. And so deciding to do it in an ethical and safe way, and I know Dr. Anai will talk about the ethics of AI and innovation, but Ideal Framework is an example of a framework that was developed for innovation. And so we use this framework to help develop this idea, and then how we would disseminate it. Because I've presented this several times, and people from all over the world want to start incorporating to their practice, but how do we safely do that while we still don't know what the long-term implications are of it? And so I started with stage one, which is the idea, case reports and series. So we first published the first two patients we did a few years ago, kind of just describing the technique so people knew that this was something that was possible. And then what we did was we moved into the stage 2A, which the Ideal Framework calls it the developmental phase. And I think this is really important. This is the phase where you actually describe how you got to where you are. So we explained the whole series of 20-some patients, and where we actually kind of got into stability of the technique. Because those first 10 to 15 cases, you're really learning as you're going. And I think it's really important that you teach other people the lessons you've already learned going through this so people don't repeat those same mistakes. So we went into a lot of detail explaining, what we did with each case, who these patients were, and what we learned from that. And so the next stage that we're in now is prospectively studying this and assessing. Obviously, we need to know long-term outcomes, but also how well other people can adapt it. And so a multi-centered study allows us to see, is this something that other people can adopt easily, and what other challenges people face. So future outcomes for this specific innovation, we still need 5-year outcomes. Our 2-year outcomes have demonstrated no recurrences thus far. I am working with a lot of surgeons around the world to see if others can adopt this as well. I'm happy to identify other collaborators if people out here want to study this in their patient population, and ultimately a multi-centered randomized controlled trial or registry is the gold standard to demonstrate, superior outcomes with this. Thank you. I'll end there.
Thank you. Our next talk is Holomedicine, Novel Innovation to Global Perspective by Zachary Yao from Singapore.
Hello everybody. Thank you, Dr. Siva, for inviting me from all the way from Singapore to come here to present to many of you distinguished guests before. I think the slides are not up.
Dr. Anai's talk on there, we can start with that.
No, I think the slides are on. It's just not reflecting onto.
It's what?
It's not projecting.
It's not projecting?
So I think the slides are here.
Which slide is it?
Yeah, this one.
Yeah, there we go.
It's not showing into the screen.
just start the.
Is it
start?
drag? Yeah, is it something you need?
No, you have to, what do you call it? You have to start the slideshow first. Go back to that, start the slideshow. Because it won't project until you start the slideshow.
Isn't there a projection setting like a 10-second screen?
Oh, there it comes. There it comes. Put this up here. The last presenter's presentation came through okay.
Yeah, the last presentation.
Yeah. Okay. It's just working.
Hello everybody, sorry for the technical difficulties. Typically, I'm usually tech support for many of the surgeons, and I think to many of you guys. I have a few disclaimers. So I am not a surgeon, unlike many of you distinguished guests. I actually am an emergency physician, but I also work in the tech office. So this is rather strange for me in terms of not being able to solve my own tech problems. I work with the hollow medicine team, and I think I'll just share a bit more about what we've been doing in Singapore and hopefully with collaborations with other parts of the world. So a few disclaimers. All work presented today represents actually research and development and work in progress. And all the studies that we've been doing has been conducted under approved ethical standards with relevant review boards. So first, what is hollow medicine? Because I think this is a new concept that I think many of you might not have heard of before. So we're sharing a bit more about our journey as a hospital in NUHS in Singapore and how we actually started this journey. So hollow medicine actually originates from this device called the HoloLens from Microsoft. I think HoloLens has been in the market. I think many people are now a lot more familiar with Apple Vision Pro and its huge launch, but it is not exactly the first device in the market. I think Meta had their own Meta Quest. Together with HoloLens, we are actually been working with HoloLens 2. So it all started when Microsoft actually organized a half-day workshop in Microsoft as well as NUHS. I think what we did was, from the iteration process, worked with the developers and software engineers and of course clinicians and surgeons to understand what are the challenges, what are the use case, and what possibilities can we use to help surgeons better their clinical practice. And I think that is actually the main point of our practice. We leverage on this technology called mixed reality. So I think many people are very familiar with augmented reality as well as virtual reality. In virtual reality, you wear the headset and you're completely immersed into the environment that is virtual in space. While augmented reality is actually just overlaying, similar to a headset display, showing you little points of information on your headset. While mixed reality actually involves a lot of different cameras that tracks the surrounding that you have and basically uses that location to kind of overlay holograms to assist you with whatever you're planning to do. We hope to use this technology to help enhance the clinical capabilities improve the clinical experience and also help in the future improve patient outcomes. So our program approach is a lot of R&D and actually building up the software for this device. So just from Microsoft's standpoint, the HoloLens 2 is not a medical device, but the thing is we have been building a lot of software together with startups in Germany to actually help enhance this experience. So I'm going to share a bit more on the first video is actually done by our director, who is a HPP surgeon in Singapore. This is actually utilizing the hologram of his preoperative patient. This is actually a hologram that was generated to help him with his surgical planning. Basically, it marks out both the liver parenchyma as well as all the vessels, as well as the bile ducts for the liver itself. This helps the surgeon with the surgical planning on where his resection is going to be, what vessels he's going to encounter, and basically where the tumor is and where the locations is to ensure good margins. So as you can see, this is actually tracking all around. Basically, it's actually still interacting with the environment itself. So he still has a perfect view of the conference room where all this surgical planning is being taken place. So I think I met a lot of neurosurgeons as well as cardiothoracic surgeons in the last couple of days, and it's been amazing to hear their stories and experience. So this is us actually using it for a case itself for neurosurgery during the actual surgery itself. We took the MRI image of the patient during for the surgery itself and overlaid it during the surgery. As you can see, the surgeon has his gloves, so he does not need to scrub out while using this device. He can overlay the MRI image directly onto the patient itself and basically have visualization of the key structures he's going to fix. So I do have the device with me, so if anyone is keen to try, because videos tell just part of the story, but I think actually having the experience to try and interact with the holograms itself is just a different experience altogether. Okay, so I think many of you are minimally invasive surgeons and laparoscopic surgeons, so we have actually also utilized this for laparoscopic surgery. Because it is a device itself, we can actually stream the feed that you're going to face in your laparoscopic surgery onto the HoloLens itself, and have you also interact with the holograms itself during the surgery. So as you can see, this is my director doing the surgery itself. So I think a lot of it is being driven by the clinician, not from software engineers just building programs that they think what surgeon would like, but actually a close collaboration between clinician and the software engineering side. So I think that's actually where I'm working quite closely between the engineering department and the surgical department. So this is actually a planning for graft surgery. I think a common challenge among transplant surgeons, especially liver transplant surgeons, is for the pediatric population. I think biliary atresia is a big challenge for many clinicians in Singapore as well. And of course, most of the transplantations usually occur from the parent cell. So I think the graft size mismatch has been quite a common problem. So we helped actually overcome many of these challenges by actually taking the CT scan of the patient, of the baby itself, and then also of the graft size that we hope to get from the parent, and utilize this to kind of overlay directly whether we need to do any graft reduction for the patient itself. So this is during the surgery itself. It helped the clinician actually estimate the graft size that needs to be harvested from the patient's parent, and then after that to be brought over for the child transplantation. We have utilized this for cardiothoracic surgery for minimally invasive coronary artery bypass. I think the main concern with minimally invasive coronary artery bypass is actually the access itself, because I think the moment you have bad access, it makes this surgery a lot more challenging compared to normal. So I think the surgeon here is able to actually overlay the holographic representation of the ribs as well as the heart over the patient's body, and it helps actually guide where the incision site should be. We have also utilized this for different protocols for ourselves for broken ribs, because you can basically overlay the CT scan directly on the patient. You know where your access is. For rib lesions as well, for patients who are either obese or very muscular, there's a bit of challenge in palpating where exactly the rib spaces are or the rib locations are. That actually overlaying these holograms as ancillary tools actually do help the clinician quite a fair bit in actually reducing surgical time, because I think the typical procedure is doing a VATS prior and then localizing the lesion and then doing the surgical incision over. So I think this case was actually one of the most touching cases for our department, because this was actually very, very significant to a lot of us. This is a story of about a 28-year-old lady with pelvic paraganglioma. She had basically multiple recurrence onto her pelvis itself, and I think at the 28, 29-year-old, I think we approached many surgical oncologists and I spoke to many of them and asked them, okay, is there a solution for this case? Because there's 3 different lesions in the pelvis, and when, of course, during operating, everything is red. It can be visualized on the PET-CT, but everything is about 1 to 2 centimeters in size. I think we approached many different organizations, J&J, Medtronic, and any visualization tool that can actually kind of help with this surgery. But I think the overall arcing statement was this patient, this 28, 29-year-old lady, needed a THPSO with a bladder reconstruction. And I think that is very, very damning for someone so young, especially she still not having a family, not being married. So I think we, of course, approached her and said, this is, of course, all still experimental. We are still in a research phase of things. But there's a possibility that if we overlay your PET-CT during the surgery itself, and you send for frozen section, we might be able to save all your reproductive as well as your urinary function after the surgery itself. So that's actually what we did. And of course, this is an alternative to completely removing your reproductive and urinary function. I think she agreed. We took the PET-CT and we overlaid it during the surgery itself. I think my director, together with the surgical oncologist, was working quite closely, and he was identifying and overlaying the PET-CT. And then every location where the tumor was, we took about 1 centimeter margin around it. We sent it for frozen section. And I think we managed to get all the 5 different lesions that was noted on PET-CT. And I think that was actually one of the driving principles of why we do this, because it actually shows a change in outcomes and actually helps improve the life of our patients. Okay, so I think we have been speaking a lot about global health. I think the main thing that you actually really need to use with HoloLens is actually an internet connection. So we have been utilizing this. So this is actually a teleconsult or a teleproctoring between a surgeon from Japan, a surgeon from Singapore, and Nepal. We've been using, this is actually a multidisciplinary tumor board meeting between many of these surgeons. And it can also be utilized during surgery, because this is actually all done on Microsoft Teams, because it's a Microsoft device. You can wear the headset. A surgeon from Singapore can see what the surgeon in Nepal is doing, kind of guide him during the process, especially if it's surgery that he's not familiar with or not done before. We can even bring up the holograms during the surgery, and annotations can be made from surgeons as far as the United States. So it is actually cross-border. And the main requirement is first the device itself and internet connection. So since 2021, the numbers, okay, I should have updated it. It's about 150 surgeries with 9 different clinical departments, from cardiothoracic to urology to general surgery to neurosurgery, and we have kind of expanded our team, where it initially started with my director, who is a HPV surgeon, and a software engineer, to 3 different data scientists, 2 software developers, network architect, as well as an implementational specialist. We have also engaged multiple universities across the world, in Germany, in UK, in Cambridge, on R&D projects, because we do want to work with different organizations and universities to kind of further validate the use of this, of holomedicine itself. It uses the multiple different sensors to kind of like help. So it's with like I said before, it's the concept of Internet of Things, and using all these different devices to feed the information back to the HoloLens, because it itself is a computer itself. We have expanded beyond surgery, not just to the surgical practice, but utilizing the different functionalities of HoloLens for point-of-care solutions. As you can see, there's many different cameras. Not only, I think there's about 6 different front-facing cameras and also about 2 different cameras tracking your eyeballs to see where exactly is your line of sight. So the 2 capabilities we kind of utilize is for vein finding as well as for ultrasound itself. So because the HoloLens has an infrared camera to track exactly where has an infrared camera that tracks heat, the difference in wavelengths, and that's how it tracks his hand. We decided to utilize this and change the wavelengths it detects to kind of identify veins for patients. Because I think for oxygenated blood versus deoxygenated blood, it actually emits a different wavelength from your skin itself. So through this, we actually utilize this camera to kind of visualize all the different veins for a patient. And it's very important for me, who is an emergency physician, because I think when you have a difficulty in cannulating a difficult vein, actually this does actually offer a different perspective. So yeah, you have a different functionalities for hiding the vein, locking the box where you do want to see the veins. Yeah, so many of the different functionalities have been built in.
You can just summarize in 1 more minute.
Oh, okay, I'm so sorry. Okay, so I think the other interesting point is actually ultrasound itself. So we have been utilizing ultrasound to actually project ultrasound images directly into the patient's body. It helps with different procedures that you do it. I think we've been utilizing it for thyroid, for FNAC, because it actually projects the image of the ultrasound directly into the patient's body, having direct visualization rather than looking at a different screen. So sorry, I know I'm the one holding you all through before lunch, so I'll try and summarize as much as possible. Yeah, so we have also used it for rehab, for occupational therapists, for patients with stroke and difficulty with hemi-neglect. It actually help patients focus on different locations for the holograms itself to help train them overcome this hemi-neglect. So as you can see, HoloLens is not just a one device for one particular use case, like one particular surgery, but we are utilizing to expand through all different aspects of medicine. Yeah, so I think this is actually utilizing a digital twin, eventually utilizing, because that's the next step. All the holograms currently are being overlaid directly by the clinician during the surgery. We're hoping for real-time navigation where the hologram automatically locks on key landmark structures and just overlays the hologram directly on the patient itself. Many of this is still up on R&D, and I think this is how we are planning to do it with the 3D mesh that we've been working on. We have incorporated haptics for training. So that's one aspect. I do know I'm short on time, I'm so sorry. For education and training for residents itself, I think during COVID-19 there was actually a pandemic where many of the medical students were not allowed into the medical wards. We actually used the HoloLens to actually get Microsoft Teams with everyone to kind of have an understanding of how the ward rounds went and during the surgery itself. And of course, intraoperative proctoring. We also have incorporated in patient counseling, allowing the patients to use the HoloLens itself to visualize what is going to be done for the surgery, and we do notice that they actually do appreciate this level of counseling. We have also engaged the medical school, teaching them different procedures like IDC insertions and venous cannulations, because we can build the training program onto the HoloLens itself to kind of allow the students to interact with these holograms and learn more from through this program. Yeah, so I think there's many hurdles and limitations. So I think, like I said, this is still in the research and development phase. We're still working towards finding many partners and collaborations with different universities and different hospitals to kind of help the adoption of this. There is still further iterations of these mixed reality devices. This is still HoloLens 2. From what we hear, Microsoft is planning to release HoloLens 3 at the end of this year. And we will have to see and adapt what capabilities they do have. So our motto is the best way to predict the future is to create it, and we're always looking for people to create it with. And then this is the wonderful team that we have. Thank you.
Thank you, Dr. Yao. Very good talk. We have one more.